welcome everyone to the last in our lecture series for our geriatric resource course. Just as you know, we have from the beginning, we said we were going to sort of progress from healthy aging through end of life. And so today we have with us Dr. Dieter from Hospice of Western Reserve, who is going to share his vast knowledge about the issues people confront at end of life. And hopefully you'll get some good information about potential resources. Before we begin, though, I just wanted to call on Michelle and Denise and see if there was anything that you guys needed to cover.
Sure, Sue. So just a couple things. Canvas. So we're getting towards the end. If you're ones that are going along and doing them with the lectures, that's great. If you're waiting, to the end of the lectures, that's fine. But if you're having trouble, please reach out to us. We can help you. We even talked about coming in person if we need to. So reach out to us, let us know, because we're in May now, we're looking at June, that we want to get that stuff completed so that there's no delays on your end. If you don't know your status, I've had some people reaching out. So please just send me an email. I can tell you where you're at if you don't know. So if you don't know what I'm talking about with Canvas, please reach out so we can get you on the right track. Okay. And then there's just a few people that were not able to make the Dementia Friends sessions that we had. So those are the only, live that we won't have an option in Canvas to make up. So let us know when we can get you hooked up. So, we can connect you to other ones that are going on in the community. Denise, I don't know if you wanted to let them know, because we are going to put the recording of if they still need an echo or a CMET and what's still available live, maybe.
Yeah, so probably this weekend I will add a couple echo recordings. You need to do 2 as well as 2 CMEDs. So I will upload both 2 CMEDs, 2 echoes. The simulation, so next week we'll be working on that. So we will be meeting next week on Thursday at noon.
Not next week.
2 weeks.
Oh,
yeah.
The following week. Yeah. We won't be here next week. It'll be the following week on the 19th.
And that'll be our final time to get together. So
right. And you don't need to worry about working. There won't be any pre-work or anything. We will do all that during our hour-and-a-half session.
Okay.
And was there something else that I missed? No, I think that's it, because we can't put a Dementia Friends recording in there.
Yeah. And the only other thing I wanted to say was, since we are getting closer to the end, and we'll talk about it more in 2 weeks, the stipend, we will go over all of that with you. We'll have our coordinator who handles that come to one either in 2 weeks, or we'll set up another meeting that we can, actually screen share and show you exactly what you need to do for the paperwork. Somebody asked the deadline in the chat. We would like you to be done in Canvas at the beginning of June. That just gives us time to process the stipend payments. Our drop dead deadline would be probably June 20th. So, if you're having trouble and we're still working with you, we can go that late, but it just creates a crunch with getting the payments out. That's the end of our fiscal year for our grant, and we need it to be on this year. So does that help?
All right.
Here in May 12th. No, we do not have a lecture next week. That's the AGS conference where many people will be attending. So we are off next week, if that was the question.
All righty, thank you. So we're going to go ahead and get started with Dr. Dieter. Just so as a reminder, if you have any questions as we go, please type them in the chat. I think the preference today is going to be that we will just keep the questions in the chat and then address them at the end. So, all righty, so take it away.
Yeah, thank you. And thanks for the segue, drop dead deadline.
Yeah.
I notice things like that, so I
I'm always
appreciate
on topic.
I appreciate being here to speak with all of you as I've done the last couple of years, because I really, I enjoy educating folks about hospice and end of life care. And so I have to kind of start out by warning you that I am at work today. And although I've done everything I can to shield myself from being interrupted, and there are actually emergencies in hospice care, I'm hoping to get through all of this. But if for some reason I need to leave early, what I will do when I'm done is send to Sue or whoever I should two YouTube links. One is a interview that I have done at Hospice West Reserve, very similar to this, to talk about the fallacies and myths and all of that about hospice care that you can have. And the second is that last fall I did a TEDx talk on end of life care. And so part of what I'm going to be talking about is contained also in that TEDx talk. So you are free to check those out if you want to. So I have to say that I noted this last year that I'm the last lecture of the series because we're going from healthy aging adult to death and dying. But I would ask that be reversed. That I think that for a lot of reasons we should start conversations with death and dying, and I'll kind of point that out as we go along today. And so with that in mind, if you would indulge me, I have a little reading that I would like to read to you. You might have heard this somewhere before. It's called Reverse Living. I don't know who wrote it. It was given to me by another physician. So here we go. Life is tough. It takes up a lot of your time, all your weekends. And what do you get at the end of it? Death, a great reward. I think that life cycle is all backwards. You should die first, get it out of the way. Then you live 20 years in a nursing home. You get kicked out when you're too young. You get a gold watch, you go to work, you work 40 years until you're young enough to enjoy retirement. You go to college, you party until you're ready for high school. You become a little kid. You play, you have no responsibilities. You become a little baby. You go back into the womb. You spend your last 9 months floating. And you finish off as a gleam in someone's eye. So I think, and I would like you to hold on to that we need to pay more attention to death and dying, even though culturally and socially and instinctively we may not want to. And I say that the benefit is that it allows you to live a more enriched and full life if we acknowledge death and dying. So we're going to talk a little bit about that today. My disclaimer is that what I'm going to mention today is kind of hospice and end of life care in a bubble. And obviously what we've all gone through over the past couple of years with COVID tremendously impacted hospice care and end of life care in this country and everywhere in the world, actually. We are now just starting to come on the other side of that. We are now just starting to return to a new normal in end of life care. But what happened over the last 2 years caused hospice and end of life care to be turned on its head. Part of that is that one of the strongest tools that we have in end of life care is being present as a human being at the bedside of someone who is dying. And obviously COVID took that away in spades. Even though we tried with PPE and protecting ourselves and everyone else, just wasn't the same. And I'm sure we're all familiar with and maybe know folks that died very alone deaths, maybe isolated in a room, maybe not having a chance to say goodbye to their loved ones. Maybe they were dropped off in the ER and that was the last time they saw anybody that they loved before they died. Despite all the heroic attempts of healthcare workers to make those deaths the best that they could be, it just was hard. So some of the things that I'm going to mention, we are now getting back to, and I'm very confident that we are going to be able to do really appropriate end-of-life care and good hospice care again in the near future. We're not quite there yet, but we're getting there. So who am I, and so why should you listen? Just very quickly, I've been doing hospice work for over 30 years, all in Northeast Ohio. I currently work at the Hospice of Western Reserve. I am sitting here looking out the window at Lake Erie. So I work at David Simpson Hospice House, which is a 40-bed inpatient unit in Euclid. So my role in hospice the last 7 or 8 years has been at the bedside of people that are dying, along with a team of other professionals that are here. But along those 30 years, I've learned a lot. I've taught a lot to medical students and residents and fellows. And kind of 2 pillars that I would like you to hold on to that I've learned during these 30 years is that the dying are our teachers. We can learn a lot from them, and that we are the medicine. It's not the drugs that I write, it's not the Versed infusion and the morphine and all those things that can be really powerful. It's who we are as individuals, human beings, showing up perfectly imperfect at the bedside of someone who's dying, to honor and validate that life, and to do what we can to help with their suffering. So what I'm going to talk about is based upon experience. A lot of it's my own opinion. So you can do with it what you want. But at the end of the day, I hope that I'll get you to start thinking about death and dying perhaps a little differently. So having said that, what I would like to do is incorporate all of you at the beginning here. And I'm sure that we have all experienced the death of someone that we love, someone that we cared for. And I'm sure that most of us have experienced what we would call good deaths or bad deaths. And so I would invite anyone, if they're willing to share very briefly with the group, if you're comfortable with it, a good death or a bad death that you have experienced that really struck you and why you feel that it was a good or bad death. I'm just going to ask for a couple examples if we can.
I'll go.
Okay.
My name is Vicki. I'm a nurse at a long-term care and rehab center. And when COVID first started, I worked on our COVID unit. And I think the death that hit me the hardest was my first COVID death, because it was in the peak of it. Families were afraid to come in, even if they were allowed. So I sat in the room with the one patient that was not doing good and held her hand and told her it was okay until she took her last breath so she wouldn't be alone. And even though I didn't know her too well, that hit me very hard.
Mm-hmm. Yeah, Vicki, if I could ask, did you consider that a good death or a bad death?
I would consider that a bad death, because if it wasn't for me being in there, she would have passed alone.
So I would look at that and I'd say that was maybe a good death, because you were there. And this is a good time for me to mention that even though I ask you to think about good and bad deaths, what I've come to realize is that those terms are very pejorative just for this reason, because somebody may look at a death and say that's good, or somebody else may say it's bad. I actually use the term and I shoot for what we call the best death possible. And I think in your situation, that's a good example, that for that patient, it was not the ideal death probably, but the best death possible. And you were the medicine. You're the one that showed up to be with that person. So thank you for doing that. Anyone else?
I have one. This is Shannon Murphy. I was a hospice nurse at an inpatient unit for 6 years in Youngstown, Ohio. And I had a patient right after we opened, and excuse me, I'm sorry, I have a cold. Right after we opened, we actually had some beer left in the building from the open house that we had. And the guy was in bed, and his daughter, she says, why isn't he dying? He's been like this for 3 days. So I went over the whole, is there anybody he's waiting for? Is there anybody that he hasn't said goodbye to? Is there any unsolved? And she said, well, I just wish that I could have had a beer with him. And I said, what do you mean? She said, before he went to the hospital, he told me to come over and have a last beer with him. And my stepmother wouldn't allow it. I still have the 6-pack at home. So I said, well, let me go see if we have any beer here. So I went and got a medicine cup and poured the beer in the medicine cup. And we had the swab sticks, the green swab sticks that you put in their mouth. And I soaked it in the beer and we put it in his mouth and he sucked it dry. I then poured the rest of the beer into a cup for his daughter. And 15 minutes later, she came out and told me he passed.
Mhm. Mhm.
So I would say that's a good death. He got to have his last beer with his daughter.
Yeah, good. Yeah, thank you, Shannon. I agree. One more.
I'll go.
Okay.
My name is Tina, and I'm a United Methodist minister. And I was able to make it to the hospital before a parishioner who had become a friend, before they unplugged the vent for her. She was very strong spiritually, very strong in her faith. And when I got closer and said, Becky, do you want to have prayer? She shook her head no vigorously. And her cousin, who had been there through it all, looked at me and said, somebody came in and prayed for her to get better. And she didn't want to get better. She wasn't in a point where she was going to get better. And I thought that was very telling, especially for those of us who are clergy, to be aware about what we're asking for on their behalf. She had made her peace long ago. She was ready to go at any time, but somebody came in and prayed for her to stay. And I thought that would have been selfish on my part to do because I wanted her around. So.
And thank you for that. That actually brings up a wonderful point and allows me to kind of transition to the next part of this, which is I would ask all of you, if you haven't already done it, and we're going to ask you to do it right now, take a few minutes. If you could wave a magic wand, how would you want your death to be? What would be important to you when you're dying? And just take a few minutes to think about that. Actually imagine your perfect death, the best death possible for you. Give you a minute or two, and then I'll just ask folks to kind of share up some characteristic or two of their perfect death for themselves. Okay, just another 30 seconds or so. Okay, so I just glanced down and I see the folks are sending messages to me and to everyone about characteristics of that. So Natalie just said she can't talk, but she would want her friends and family wouldn't mind where I was located if it meant the people I loved were around. 4 days after my 100th birthday in my sleep, when I sleep with God waiting for me, closure free of pain. Anyone else want to share anything that would be their best death possible?
This is Vicky again. I put mine in the chat, but I would want to have a glass of wine and have my son holding my hand until the end.
Anyone else?
I put in the chat too. I just want die when I sleep, quiet and waiting for God to meet me there.
Okay. Well, thank you for sharing that both verbally and also in the chat. And so that really, you know, that's one of the points of hospice, is to allow a person to have the best death possible in the way that they would want to have that death. And that is part of what the goal and the role of hospice care is. I would also say, as was pointed out here recently before the transition to this, is that we cannot assume that we know what's important to somebody else when they die. So we need to find out what's important to us. So when the time comes, the people that are important to us know what we want. But as I hope I have time for, I also think that's a good place to start with advanced directives. But we need to ask folks, we need to honor how they want their death to go and try to make that happen if we can. Now, if you query a lot of people about what they think a good death for them would be, there are some pretty standard characteristics, and you guys mentioned a few of them. Being out of pain, having a sense of closure, having friends and family around, having lived a good life, not suffering, dying in your sleep. All of these things, we kind of paint this picture of how we imagine most people would want to die. But there are folks that's not what they want. I've met a lot of people that say, I want to be young, I don't want to see it coming, and I just want to drop over, maybe playing basketball, which is what I love to do. I don't want to get old, I don't want to get frail. Other folks will say, you know, I want to be asleep. I don't want to feel any pain. I don't want to feel any suffering. On the other hand, there are folks like Tibetan Buddhists and other groups that want to die with their eyes wide open, which is, I don't want to be sedated. Whatever it is I'm supposed to experience, I want to experience it. I want to go through this feeling everything. So we can't assume. And that's kind of how hospice approaches things, because if we leave it up to the standard medical system, oftentimes we don't get that opportunity. So we live in the most death-denying culture that's ever existed. And there was actually a book written in 1974, The Denial of Death, where the author, who was a Pulitzer Prize winner, went back and looked at the approach to death and dying through every culture that's existed. And we are the most death-denying culture that there is. And, you know, that really is, it's surprising and not surprising in a way. Actually, 100 years ago, most people in America died at home. They were surrounded by friends and family. The community around them knew what it took to take care of them. And children grew up in homes knowing what death looked and smelled and sounded like. Sometime after World War II, because of medical technology and patient autonomy and consumerism, our society and culture decided to move care of the dying from the home into the hospital. We thought, yeah, you know, doing so much good with healthcare, maybe they could manage dying, and we don't want to do it at home anymore. So you started to have generations of people who grew up not knowing what it was like to be around someone who died and didn't really want to consider that death is really part of being alive. And so the thought was that we could do a really good job in the hospital of managing death. The problem was that we don't, and we didn't. We're getting better. In 1995, I believe it was, the support study came out. It was a national study, 6,000 patients who were hospitalized, and they were in some process of dying. And the data that we got from that study did not really support the fact that a medicalized death was necessarily a good death. Most of the time, the physicians caring for the patient didn't know what their wishes were. A big proportion of the patients died in moderate to severe pain in the last 10 days of their life. A lot of folks died in the ICU. Families felt that they weren't communicated with. They didn't know what was going on. So we learned that a medicalized death really kind of was not the best death possible, that we forgot a lot of what we knew prior to 100 years ago. And what hospice does is kind of allows folks to have a non-medicalized death to a certain extent. So where did hospice come from? And for some of you, clearly you already know this, so I apologize, but I think it's good to understand what we're doing now, where the roots of that are. So in the 1960s, Cicely Saunders, who was a social worker in London, realized that the care of the dying was not adequate there. So she went back to school, ultimately became a physician, and she opened her own facility called St. Christopher's Hospice in London, which is still there. And the wisdom that she brought to that facility was wisdom from the Middle Ages, from the Ars Moriendi, the art of dying, where without medical technology, there were pretty adequate and effective ways of being with people who were dying. It was really based upon several of the major religious traditions at the time who actually got along pretty well and provided care and comfort, dealt with people suffering in a variety of different ways. One thing that was very clear to Cicely Saunders, who later in her life became Dame Cicely Saunders, was that we cannot by ourselves adequately care for someone who's dying because it's complex. So she said, as a physician, I can't do this. I need help. So she gathered a team, doctors, nurses, social workers, bereavement specialists, volunteers, spiritual care providers, all kind of folks to deal with what she called total pain. In total pain, when folks are dying, is physical, psychological, spiritual, emotional. All of that is wrapped up together. She also understood, as we do now, that caring for someone who's dying requires us to care for their caregivers, for their loved ones, because the suffering of a dying person is transmitted back and forth to the people that love them. So we have to encircle all of them and take care of all of them through the process. So that's what she did. And that vision of hospice care thrived, and it came to the United States in 1974. It was the nursing profession that said, this really sounds like a good way to take care of people that are dying, as opposed to what typically was done. So they started hospice, it started to thrive, and then because most of the patients were elderly, they were Medicare. So Medicare looked at this and said, what are you doing? And once Medicare looked deeper into this, they said, we need to be involved in this. And Medicare developed the Medicare hospice benefit, which exists today. And with that guidance and direction, the Medicare hospice benefit said there are 3 criteria for hospice care. The first is that the patient is terminally ill. And so at that time, we didn't really know what the definition of terminal illness was. And because most of the patients actually had cancer, they looked at cancer survival studies and realized that 6 months was the least time frame that we could look at to see if somebody lived or died. So they said, well, if a person is going to die within 6 months, and 2 physicians would say that's true, then they are terminally ill. So that became criteria number 1. The second criteria is the patient would need to understand that this was not curative care, that this was comfort-directed care, so that there was no coercion. And the third was that they wanted physicians to be involved. So they said there needs to be an attending physician involved in the care of the patient. And so the physicians were kind of looped into this team approach to care. And those are really still the 3 criteria. What has changed is the approach to terminal illness. At the beginning of hospice, Medicare was pretty strict. And they said that if somebody doesn't die within 6 months, that's not a good thing. And actually, I can remember doing hospice in the early 1990s, where physicians in programs would be financially penalized if they enrolled a patient who didn't die within 6 months. They said it was Medicare fraud, that you said they're going to die and they didn't, so we're going to penalize you. So what happened? Well, a couple things happened. One is that physicians were very reluctant to refer their patients until they were on their deathbed. And secondly, there began to be kind of a pushback that we need to kind of look at that criteria again. So what came out of that is what we call the surprise question. And Medicare asked the physician, would you be surprised if this patient dies in the next 6 months? And if two physicians can say, no, that wouldn't surprise me. They're sick enough that they could die. 6 months, 180 days rolls around, they're still with us. Medicare comes back to us, said, do you still think that they meet that criteria? And so every 60 days, that patient has to be recertified by a physician or a nurse practitioner with that hospice program, looking at the patient saying, no, I still think that it's likely they're going to die in the next 6 months. So those are the criteria that we still go by. Some people say, well, doesn't a patient have to be a DNR? No. When hospice first started, that was kind of like in parentheses, the fourth criteria. But Medicare said, no, you can't do that. That's discrimination. So what happens is that we don't exclude folks from entering hospice if they want to be a full code. We look at that as an opportunity to educate them, to educate the family, and to go on their journey with them and allow them to make the best decision for themselves. Some people end up dying in hospice as a full code. And at the time of death, families call 911, and those kind of things can happen. Mostly though, with education, with time, the patient realizes, CPR isn't what I want. One example of how that can happen that I'll give you very quickly is that let's say I get cancer and let's say it's lung cancer and I go see the pulmonologist, then the oncologist, and they outline with me all of the treatment options and what the benefits, the burdens are, what the success rate may be. And then I go back in for a reassessment after some treatment and I get rescanned and the oncologist says, I got bad news, but this isn't working. So I'm going to send you to hospice. So that's out of left field. I just got sucker punched. Nobody ever said that this might not work. I wasn't prepared that it might not work. And the next day the hospice team shows up. And so you can imagine one of the questions they asked me is, what are my wishes for CPR? And without time to process this, without being educated about the goals and the downsides of CPR, I'm going to say, of course I want it. So that sounds maybe a little far-fetched, but that still happens. That is a common reason why people are not ready to be a DNR winner when they enter hospice. So let me talk about, so I have a whole list of questions here that they asked me to address. So I try to put them together a little bit. I think what feels right to talk about next time next here is the mechanics of hospice. So how does that happen? What works? How does it work? So anyone can make a referral to hospice. The patient can make it, the family can make it, a physician can make it. And the physicians that may make a referral to hospice can be the patient's primary care physician, or it can be a physician that is managing or has been managing their life-limiting illness. For instance, an oncologist, a pulmonologist, a cardiologist, a neurologist, depends upon what the terminal diagnosis is. But the initial referral does not need to come from the physician. Once the patient or family reach out to a hospice program, though, that hospice program is going to need to contact the patient's physician or physicians to gather medical data to see if that patient qualifies, if they truly are terminally ill and would benefit then from hospice. Once that referral is made and the data is gathered, the patient and family caregivers, if they have them, are approached by the team members. Every hospice does it differently. Sometimes there's a social worker, a nurse, a team that goes out, educates them about what the program is, make sure they understand what the goals are, what the benefits are. And then once the patient is enrolled, they have their own team of healthcare professionals. This is the key to hospice care. This patient and their family are going to be cared for by a team of professionals who are compassionate, who are well-trained, whose focus is to meet that patient and family where they are, to address their total pain, to go on their journey with them. And the second part of kind of the goal of hospice, not only to allow the kind of death a patient wants, but just as important is to allow them to live as long and as well as they can. So one of the myths of hospice is a place you go and they give you morphine until you die. Now, do we use morphine? Yes. Are there locations where hospice care is provided? Yes. But the majority of hospice care is provided in the home, whether that's a house, an apartment, a condo, a nursing facility, assisted living facility, a prison, a group home, or in a box under a bridge. Wherever the patient is and they need the care, the hospice team will go there. They address, because we have medical folks and social work and bereavement, and spiritual care providers, all of the aspects of total pain are addressed. Every 2 weeks, that patient is discussed in a team meeting. That's a requirement of Medicare, to find out, make sure everything's being managed, to see how they're doing, to have the team members work together to provide the best care possible. It's interesting that when hospice first started, the team was called the interdisciplinary team. And that was to distinguish it from multidisciplinary, which is the common model in the hospital of a committee. A multidisciplinary committee is a hierarchical committee, usually led by a physician or a hospital administrator. And so the decisions in that committee are filtered through that person at the top before anything is done. With an interdisciplinary team, everyone is equal. The physician has just as much say as the home health aide. And you work to find a consensus as a team on how best to take care of that patient and family. What we have learned after doing hospice is that the team is actually transdisciplinary. It means that each of the team members learns from their colleagues. So the spiritual care provider starts to pick up on medical and nursing aspects that they could bring to the table when they're interacting with the patient and family. Likewise, physicians could learn some spiritual care approaches and be aware and cognizant of that when they're working with somebody. So it's a more cohesive unit. So any problem that comes up in the journey of the patient will be addressed by the hospice team. If it's a crisis, let's say it's a pain crisis, it's 3 o'clock on New Year's morning, and the family calls hospice. Most of the time they will speak to a human being who will try to fix the problem over the phone. If they can't, they will send a team member out. Outside of hospice, if that patient calls, they will probably get a physician that doesn't know them, that may take a long time to return the call, and probably will say, just go to the emergency room. So it's immediate access to this team 24/7. And the skill set that the folks on the hospice team bring is tremendous. And so each discipline is well trained and well skilled in what they do. And I can tell you that never say always, never say never, never say every, but I would say that most The vast majority of hospice nurses I've worked with in 30 years know more about pain and symptom management than many of the physicians that I work with that aren't in hospice. They are really good. They know what they're doing. They can be trusted. And so, as I mentioned, we meet the family where they are and we accompany them on their journey. And remember that most folks have not been around someone dying before. So part of our work is to shepherd the patient and the family along the dying process, to tell them what to expect, to explain what they're seeing and hearing and smelling, to allow them to be angry and sad, and to hold on to that, to hold the space, to let them know that we cannot fix every bit of suffering that we see, that sometimes suffering just has to happen, and that we can model for them how to sit with suffering and to just show up and how important that can be. And then when the dying process is very active, then we really focus in on supporting that patient and family. So again, most of this happens at home, but many hospices have an inpatient unit, such as the one that I worked in, where folks can come in and get like intensive care for hospice, either at the end of life or if they have symptoms that are out of control. So what are the diagnoses that we see? Hospice takes care of just about anything that meets the criteria that the patient's likely to die in the next 6 months. Initially, as I mentioned, many hospice patients were cancer folks. That's still the case, but we take care of any end-stage neurologic condition. We call it brain failure, renal failure, heart failure, lung failure, dementia, and I'm going to hopefully have some time to talk a little bit more about kind of the difficulty and the interface with dementia and hospice. But the one that is still very common that we have to play a game with is what we used to call failure to thrive. Many people, as they get older, just tire out, and they have many medical conditions that as a whole combine to lead to their death. And just as in pediatrics, where we have failure to thrive with newborns, we have failure to thrive with elderly, and they just have a natural death. The problem is that Medicare will not allow us to use that term as a terminal diagnosis. So this is where it might get confusing for people. We know it's a combination of things, but somehow it falls on the shoulders of the hospice team to figure out what's the most dominant medical condition that we can document and make Medicare satisfied. And so sometimes we play games with the diagnoses and it confuses people. But at the end of the day, folks are dying because it's just time for them to die. Things are wearing out. So I think that's that. Let me, and again, questions if you have, shoot them to Sue, and I, at the end, take as much time as we need to answer any of these questions. But what's the difference between hospice and palliative care? That's a big question and concern still. So here's the history. So you know that hospice started, and back in the early 1990s, there were a lot of people that we saw that would benefit from hospice, but we weren't really sure that they met the prognosis criteria. So there was a movement in the hospice organization. I remember being at the national meetings where physicians would stand up and say, there are other people that need this, but they don't meet the criteria. So what was decided upon is that we would take the hospice concept of care, addressing total pain, caring for the patient and family, and move that upstream in the illness, so that anyone in the process of their illness could access a team approach that would help them deal with symptoms, that would help them deal with goals of care, that would give them support. And at the same time, they could still get treatment for whatever the terminal illness was. It wasn't either or. Prior to palliative care, The model that we followed was the over-the-wall model, which is the medical community would do everything they can to save someone, to treat someone, and then it would, when it became so obvious that the patient was nearing the end of their life, the medical community would say what they should never say, and no one should hear, there's nothing more we can do for you. And they would metaphorically throw the patient over the wall and walk away. On the other side of the wall were the hospice folks to carry on. And so we said, we got to get rid of that wall. We need to have a transition. So that's what palliative care became. It's taking some components of hospice care and allowing patients and families to access that early on in their illness. The two most common ways that that plays out are symptom management, and secondly is talking about goals of care. Helping folks remember that example I gave you about me getting lung cancer. If I would have had palliative care in that scenario at the beginning, I would have known that there was a chance that this might not work, and what would my wishes be in that case. So palliative care is there to augment all of the other care providers and to help the patient and family kind of guide them through the process. Problem is that after all these years, it's still misunderstood. Physicians don't understand it. They think it is hospice care, and because they don't, as a result, they won't refer folks for palliative care. The general public is confused. There has actually, for the last 5 or 10 years, been a movement in the hospice palliative care world to get rid of the word palliative care and to call it supportive care or comfort care or integrative care, so that maybe it wouldn't have this stigma. And there are places that do that, supportive oncology programs, et cetera, where they are really incorporating palliative care. One of the myths about palliative care, and it's particularly prevalent in oncology, is that it makes the patients die sooner. Studies have been done that patients with cancer who receive palliative care live longer and do better than if they don't receive palliative care. Again, it's complementary. So we still have a lot of work to do with that. One of the downsides is that palliative care is not reimbursed by the government like hospice care is. So it's been slow to grow. And we're starting to realize that we don't have enough fellowship trained hospice and palliative care physicians to go around. And so there's been kind of a shift that we're starting to say, well, maybe instead of having a lot of specialists, we need to make this more of the primary care education, that every physician learns a little bit about palliative care so that they can begin to incorporate that into their routine care of their patients. That's a lofty goal, but I think it's a really wonderful goal if we can get there. So the next thing that I see on my list here is, what about caregivers at home? So this all sounds wonderful. You know, you are able to live as long as you can and as well as you can at home, surrounded by your loved ones with your caregivers. But that's not an easy thing to do. This is a lot to ask of our families. So many repercussions. Families have to take time off of work, even though the will is there. It's hard to care for loved ones when they get really sick. And even though the hospice team tries to support them, the hospice team is not there 24/7. So it can take a financial toll, it can take an emotional toll, it can take a physical toll on the health, on the families that are providing healthcare. The other thing we have to remember, and we get reminded of this every day in hospice, you know, there's a term dysfunctional family, which I don't like that term because every family is dysfunctional. My family is dysfunctional in its own way. It functions, but if somebody from the outside were to look at it, they wouldn't understand the dynamics. So the hospice team has to go in and try to figure out the dynamics of each family situation. And sometimes it just doesn't work. The other reality that we face are the social determinants of healthcare, is that there are many patients that end up in hospice because society fails them, that they have a chronic illness that if they had adequate support, if they had a ride to the physician, if somebody would be able to pay for their medications, if they had somebody to remind them how important it was to have follow-up, that they wouldn't end up in hospice. They end up getting episodic acute care through the emergency room. And then what happens is, after so many admissions, is that the medical team at the hospital says, you know, we throw our hands up, let's send them to hospice. And here's what happens, folks, is that we take care of these people. We give them all the medications they need. We give them all of the care that they need. We give them the support that they need. And all of a sudden, they are no longer hospice appropriate. They're not dying anymore. And so that becomes an area of moral distress for the hospice team, because we know that we're going to be forced to discharge them, but we know what's going to happen. So that is a common scenario that we face. Just very quickly, when I first started here, one of the first patients I took care of was a 34-year-old woman who had the emotional development of about a 12-year-old. And she had given birth to 3 children. All of them were taken away from her. Her first child, it was a very fractured relationship, but she developed postpartum cardiomyopathy after the last delivery. And she had progressive end-stage heart failure. And because she didn't have a supportive family, she didn't have money to do what she needed to do, she ended up getting acute episodic care. She didn't qualify for an LVAD. She didn't qualify for a heart transplant. So eventually the cardiac team sent her to hospice. She came to us on a dopamine infusion, and the instructions were stop the dopamine and just let her die. Well, the problem was nobody told her that. And she had a defibrillator. And so our task was, how do we take care of this young woman who is dying from heart failure because of the social determinants of healthcare, who's being currently kept alive on a drip? Long story short, we were able to work with all of that, and she lived another 1.5 years. She stayed with us because she had nowhere to go. We celebrated her next birthday. Staff took her shopping in Amish country. I mean, it was just a wonderful story, just to show what can happen when hospice gets involved, when other ways for folks to get the care they need just isn't there. So while I'm talking about this, it prompts me to mention folks that enter hospice, then we have to discharge them in other situations. And so let me transition a little bit to dementia. So a common scenario in dementia is that as the patient progresses through their functional decline, they need to meet a certain level of function in order to qualify for hospice. We use the FAST scale, and we add some other things to that to see if it's likely that they'll die in the next 6 months. So as most of you know, folks with dementia may end up with a UTI or pneumonia. They're in the hospital. It looks like they're dying, so they're referred to hospice. And so they get discharged and they don't die, they recover. And when they recover, they're not sick enough to be in hospice anymore. So for those folks, we have to discharge them. And we try to stay involved as long as we can, but we can't always do that if they're getting better. The other aspect of dementia and hospice care, besides that, is one of probably the most distressing for us, is that when folks with dementia have extremely unmanageable behavioral difficulties, they can't be managed at home. They go into the geropsych unit and they won't take the medications. So then they send them to hospice. So we get them usually in our units, and they have a good functional status. Their PPS is 40 or 50. They're up walking around. They still may eat now and then. They wander. We can't keep them in their room. And our task is because they're maybe yelling or screaming or doing these things, is that we need to medicate them. We don't have the resources to do milieu therapy. We don't have non-pharmacological ways to manage their behaviors. So to protect staff, to protect other patients, we need to medicate them. And when we medicate them, eventually it leads to sedation. And so in my mind, what happens is we are accelerating their dying process. So I say that just to make folks mindful that sometimes hospice is not the answer for folks that have dementia and have severe behavioral problems. We need to find a better way to manage them. I think it's one of the places where folks fall through the cracks, and we need to do more work there. So I do want to circle back and just mention, what does hospice provide? I told you about the team approach to care. Hospice will pay for and provide all of the medications related to the terminal diagnosis. So if they're dying from heart failure, we pay for their cardiac drugs. We will pay for their anticoagulants if they need them. And we are obligated to pay for all of their symptom management medications. So whether it's pain, shortness of breath, anxiety, nausea, constipation, delirium, pruritus, it doesn't matter. We will pay for those medications. We won't pay for things that are unrelated. So if somebody is dying from heart failure, we don't necessarily manage their diabetes. That is separate. Medicare pays for that a different way. We provide their DME in the home, a hospital bed, oxygen, anything else that they'll need. All of the visits and everything else is paid for. It's free for them. There's no charge. And so that alone is one of the reasons why this is a benefit for patients and families, because they are getting all of these things that they couldn't afford or other folks wouldn't provide to them in the past. So once a patient enters hospice, they will leave in several ways. One is that they will die at some point in time. It may be in 3 days, it may be in 3 years if they continue to qualify. If they improve, we will discharge them. And when they get sick enough again, they can re-enter, or they can revoke. And some patients or families say, this isn't for us. Mom has cancer, but my cousin said that we should go to this clinic somewhere and try something there. Perfectly, absolutely, wonderfully fine. We will do everything we can to make that revocation go smoothly. And then down the road, they can always come back if they need to. During the time that they are with hospice, as I mentioned, we have to recertify them. They are also entitled for periods of respite, which is usually up to about 5 days outside the home to give the caregivers a break. And so that's usually provided as well. What about bereavement? Huge benefit. So hospice programs are obligated to provide bereavement services to the family after the death of their loved one for usually about 13 months. We like to cover that 1-year anniversary. It's not forced upon families. It's offered. It's available. There's a variety of ways that it can occur. As we work with families, we identify high-risk bereavement people, and we make sure that we intensify our efforts to make sure that they feel supported. We have bereavement specialists, grief specialists that work with folks. So that's a very strong part of the program. We also depend upon volunteers. Medicare says that hospice program need volunteers. These are folks from the community that do exactly that. They volunteer their time, their talent, their treasure, their skills to do all kinds of things, whether it's stuffing envelopes or sitting with dying patients if they have kind of doula or dying vigil training. At our facility here, again, pre-COVID, every Tuesday evening, one of the local restaurants would come in and provide a dinner for all the families, white tablecloths, 3-course meal, just that kind of stuff, all volunteer stuff. Musicians, all of those kind of things can come into the inpatient facilities. So let me swing next to talking about some of the other misconceptions that there are about hospice. One is, and I referred to this at the beginning, that hospice is a place where you go and they give you morphine until you die. Well, sure, there are inpatient units, but the majority of patients never end up here. Yes, we do use morphine and other opiates, but we don't intentionally give morphine and opiates to end someone's life. And I really want to spend a little time on this because it's important to understand, if you don't already, is that morphine and the other opiates are very, very powerful medications to treat pain and shortness of breath. And if used diligently and carefully and mindfully, we can manage, or mostly manage, those physical symptoms without causing excessive sedation or accelerating the dying process. I can guarantee you that every hospice clinician that I've worked with never intends to just sedate somebody to either end their life or to, quote, put them out of their misery, although we are asked to do that a lot by the patient and family. That's not what we do. We use the medications the right way, and they can be extremely effective. And so why do I focus on this? Because there is this misconception that that's what we do. And, you know, there's a lot of folks in the general public that really don't like morphine. They don't like the term opiate. And they will push back. They will not let you medicate their loved one. A patient sometimes will refuse it. They have concerns. Legitimately, maybe they've had a history of substance abuse disorder, and we know that, we will know that, and they are reluctant to use those medications. And we work with those folks. There are other folks that are worried to have those kind of medications in their home because they think somebody they know will abuse them, or that they will get robbed and those medications will be stolen, or that they don't want to be labeled an addict. There are all kind of reasons why people push back. And the best that we can do is continually educate them, be mindful of what their concerns are, and work with them the best that we can. Another misconception is hospice means giving up. That I don't want my dad to have hospice because he's not ready to give up. And unfortunately, I think the healthcare system facilitates this belief pattern a little bit. For instance, if a recommendation is made in the hospital for a patient to receive palliative care, a lot of physicians still say, oh, they're not ready for that. They're not ready. And they misconstrue palliative care with hospice. And then they will often say, because they're not ready to give up yet. We're not ready to give up on them yet. The reality is that most of the patients that I've taken care of over the last 30 years, when they enter hospice, they know why they're there and they're ready for it. And if you ask them, you know, why are you in hospice? Well, I'm dying. They know. Their families may not say it out loud or may try to protect them from the reality, but the patients know when they're dying. They know when they're getting sicker. And so, so this is, you know, this is a non-pharmacological part of where we do our work in helping families understand that it's not giving up. And that takes some skill. We have to understand the patient's narrative. And it can become difficult because, as you know, when folks have cancer, you know, our narrative for a lot of people is that they're fighting their cancer. And so all of a sudden not fighting the cancer anymore may seem to some people like they've quit or they're given up. And so there are very skillful ways to support and work around that. The next thing that I want to mention, personally, I think this is the most important part of dying, is that dying is a spiritual process. There's a medical component to dying, but what's really happening in that room is not medical. And there's mystery, there's wonder, there's awe, there's things that we can't measure. And the reason why that's important is we need to make space for that. And I think that a good way to approach entering the room of someone who's dying is to say and to understand that this is sacred space. This is their space. They are doing the work that they need to do to end their life. And we need to allow that to happen. And that shows up in a variety of ways. And as clinicians, we need to recognize that so that we don't over-medicate things that don't need medicated. People, as they're dying, as many of you know, start to vision. They will see and talk with and communicate with deceased loved ones. They will reach up, they'll stare in the corner of the room. They'll get terminal restlessness. They'll try to take their gown off, their sheets off, and those kind of things. That's part of the dying process, and we have to honor that. Again, another reason why spiritual care providers are so crucial, and chaplains, in reminding us of all of that and attending to the aspect of total pain, which is spiritual pain. So much of the restlessness at the end of life is spiritual pain. It's about relatedness, forgiveness, meaning, hope, those kind of things that we need to address without medication. And although those things can be hard to watch, and it can be hard to sit with someone else's suffering that we can't medicate away, the potential for healing and transformation is always there. I cannot begin to tell you how many stories I've heard from folks as they're dying about what they're trying to tell me or others that they are experiencing, about what they're seeing. The ancient Celts talk about the veil parting before we die, and we get an understanding of what's happening. Patients, people, when they're experiencing that, can't find the right words. They use symbolic language. They try to describe colors and sounds and what they're seeing, and the words are inadequate. Relationships can heal. I mentioned dysfunctional families. I've seen so many dysfunctional families become totally functional at the time of dying. Healing occurs. Forgiveness is given and received both ways. So it can be really wonderful. It doesn't have to always be this time of dread that we want to run away from. So I think the last two things I just wanted to mention, I already kind of mentioned at the beginning, is the two kind of tenets that I follow is that the dying are teachers. We can learn what's important in life and how to approach death with grace and dignity and courage. And that to understand and to give ourselves credit that we might be exactly what that dying person in front of us needs. Even with all of our faults, we don't have to be perfect. Just showing up as we are, not running away, being willing to sit with somebody is often more than enough. And so with that, Sue, I don't know, have you gathered some questions? I see some things flickering here, but I haven't read any of them. Are there things I should address?
No, one question is the difference between a for-profit and nonprofit hospice, and maybe in general, are all hospices the same?
Yeah, that's usually a common question. So, so not all hospices are the same. And so what started to happen after hospice got a foothold is that some folks started to look at hospice as a way to make money. And so they went into the business of hospice to make money. And so what happens, unfortunately, in that is that some of the approaches and some of the care and some of the decisions that are made are not made in the best interest of the patient and family. They're made in the best interest of the bottom line, the dollar, and the shareholders. With a nonprofit, not-for-profit, that's not the case. And it's probably a good time to say that hospice, by its the way that it's structured, is not a money-making process. We get reimbursed per diem per day for every patient from Medicare or any of the private insurances that usually model Medicare, a certain amount of money every day to care for the patient if they're at home, a different amount if they're in the inpatient unit, a different amount if they're in respite care, that kind of stuff. And so it's not a lot of money. it has to pay for all of their medications. You guys know how expensive medications are. So if you have a patient that's on, 5 or 6 different comfort meds, that's right there. That's a lot. And so I can tell you that the per diem doesn't come close to covering that for most patients, let alone the salary of the people that are doing the work and the administration fees and the overhead. So most not-for-profit hospices survive because of donations. And thank goodness there are people out there that realize the good work that hospices do, and they support and they donate and they do fundraisers and they bequeath money through living wills and living legacies to keep not-for-profits going. But the beautiful thing about not-for-profits is, in the ones that I've worked with, is that we do not look at a patient and say, we can't afford that. If we think that it's going to help the patient and family, including a radiation treatment for a painful bone metastases, that's a lot of money, or blood transfusions, or this or that, if it makes sense in the plan of care for comfort, we'll do it. A for-profit, not likely to do that. And as a matter of fact, so, I could live with that, but where I get a little more upset with for-profits is, a number of years ago, they started to go into nursing facilities, and they would kind of look at most of the people in the nursing facility and say, oh yeah, they qualify. And they would sign up people. And so all of a sudden, there were all these folks that they were getting paid a daily fee to manage in a nursing home that weren't really dying. They were just chronically ill. And Medicare caught on. And Medicare said, whoa, we got to stop this. A couple big hospice programs got penalized. Others got shut down. But the other thing that happened, and actually there's 2 sides of this coin, one's a good and bad, is that Medicare started making us do face-to-face visits for recertification. That they said after the first 180 days, if you're going to recertify, you need a physician or a nurse practitioner with your agency to go look at that patient, lay hands on them, and tell us you still think that they qualify, as opposed to just signing them up and 3 years later, they're still alive and nobody's really checked in again. So I guess that's the background. My preference, if it's my loved one, I would prefer a not-for-profit, because I just think, generally speaking, that I would trust the care a little bit more.
Is that readily obvious which category they fall in for the average person trying to find a hospice?
Yeah.
Okay, we have a comment about sometimes the family can be the most challenging part of enrolling somebody in hospice, where somebody may be more closely, living closely with the patient might want it, and out of town person might say, no, you need to do everything and we're killing them. So I don't know if you want to comment on that.
I do, yeah. So that gets more to kind of like the goals of care and the advanced directive issue. That scenario, we used to call this is what was said, I'm not trying to offend anybody, the distant dysfunctional daughter syndrome, that you would have this plan of care figured out for someone. And then in this narrative that people joked about, the patient's daughter would fly in from California, usually was a nurse, and hadn't had anything to do with the patient's care for the last year or two, while the local family was doing all of the hard work. And this family member would come in and blow it all up. And they would say, how dare you? We can't give up on mom. We've got to try this. We've got to try that. We all know where that comes from. That's primarily guilt driven, that they haven't been around and those kind of things. But you find ways to deal with that, but it's still a common scenario. And so if I can, and I know we got about 15 minutes or so, but one thing that I would just like to comment on about advanced directives is, the metaphor that I use is that, oh gosh, I'm blanking on his name now. Indiana Jones. In all of the Indiana Jones movies, there's usually a scene where he's running through a forest, he's dodging arrows, he's ducking under limbs, and he trips over a stump and he rolls down a hill. And then all of a sudden his eyes light up and it looks like, good, I'm safe. And he runs, and then all of a sudden there's a 10,000-foot drop off. And it's like, I thought I made it, and now what? I liken that to the healthcare journey. And I think advanced directives are the way to get somebody through the jungle, to avoid the arrows, to pick them up when they trip, to get them going in the right direction, so that the kind of healthcare that they get as they get sicker is what they want. But what we don't do is, when it comes to the time of dying, nobody's prepared them for death. And so my recommendation is, start with death. Say to someone, imagine your own death. How do you want it to be? And all of the things that you guys have mentioned, start there. And then say, what decisions do I need to make upstream to get there? What's going to allow me to get there to that kind of death? It makes talking about advanced directives more real, more practical, instead of saying, okay, let's just say, do you want CPR? Do you want nutrition? Do you want hydration? You know, that's all theoretical, and they're not really going to think about it because they don't think it's going to be them. But if you really make them think about their death and work backwards, it usually works better that way. And I think healthcare providers need to have a more honest discussion about CPR and what it really does and what it really doesn't do. And that really solves a lot of problems. You know, in our state, we don't have a MOLST, or we don't have a POLST yet. So we still kind of have the archaic, code statuses that we have. MOLST and POLST are documents that allow you to outline exactly what you want and what you don't want. So we're getting there. But I would just, if you're having those conversations, start with the dying process. And one tool that I would encourage you to get, there's a card game called Go Wish. You can find it online, and it has 36 cards. I should have brought one with me, but each card has to be surrounded by loved ones, or to be clean, or to be at home. And it's 36 cards that each one says one of the things that you people thought you'd want when you're dying. And you play this with your loved ones. And there's different ways to do it, but you just go through it and say, what 3 are important to me? And then you have your spouse or your children, and they do the same thing. And then you talk about it and say, Dad, you said that that what's important to you is that you want to be clean. What does that mean? And then have Dad say exactly, I don't want to be laying in poop and pee and have you guys have to clean me up. That gives that family a lot of direction about what they need to be thinking about. So there are tools to have that kind of conversation, to start with the dying and then move upstream.
Yeah, I really like what you said about the CPR too. The statistics are, versus what you see on TV, right? I think TV's done a great disservice. On TV, everybody survives getting shocked, right? As a matter of fact, they just get up and walk away from it. So it's really painted a distorted picture of the outcomes that you can really expect.
Yeah, Sue, there was actually a study done a number of years ago where they looked at 97 episodes of TV programs that had a scene of CPR. And you're right, almost all of those showed the patient like up and walking the next day.
Yeah.
It did, and that's what the general public thinks. And so if we ask them, oh, if your heart stops or you quit breathing, you want us to do everything, right? Well, if that's what I'm thinking, I'm gonna say, yeah, do everything. But if that's not fair, because that's not what happens.
Yeah, that more information or knowledge needs to be out about that.
Right.
There was a question about, Michelle was just wondering, she said, I'm sorry, I can't see. Palliative care is not paid for by Medicare, is that correct?
Correct. It's a whole different billing system. So it's not reimbursed like hospice is. So as a palliative care provider, you can do like a consult, and you bill it primarily on a symptom. as opposed to like other management things. So there's some games we have to play, but it hasn't worked its way into the reimbursement system very well yet.
Heather wondered about the medications you brought up, that the ones not related to the terminal diagnosis are not covered. Does Medicare cover them otherwise?
Yeah, yeah,
Okay.
they do. And we actually have to jump through a lot of hoops for Medicare to make sure that there's no double dipping and those kind of things. So yeah, there's a lot of scrutiny paid to that.
Karen just put an observation. I think when you were talking about the out of town, said that happened in her husband's family, where they had to move the mother to be by the daughter at great expense. Shannon has said that DNRCC, DNRCCA in Ohio is very confusing. She says Pennsylvania has a nice system, so not sure about that. Carol Powell just said, wonderful presentation, of course. We all agree with that. Working backwards, I guess, is something, a new concept, so great. Vanessa is wondering, is there a difference between palliative care and pain management?
Yeah, so there's a really good question. There's a big difference. Pain management are docs and teams that are geared toward just treating chronic pain for somebody, no matter where they are in an illness. Palliative care, one of the things that we do well is manage pain. Here's the problem, that because of the opiate epidemic, that most physicians now don't want to prescribe any pain medicines. There are all these limits that we have to follow in the state of Ohio about how, if you're not doing hospice, if you're doing family medicine, you got to be really careful about how much pain medication you prescribe. And so the average person who just needs pain medication can't go to the average doctor to get it. And so there's some stigma still attached with it, but at the end of the day, they don't get what they need. So then they get punted to the pain management doctor. And the problem is that the pain management physicians are overwhelmed with the number of patients coming to them. Their forte is really intervention, like pain management intervention, nerve blocks and those kind of things. That's what they really get schooled in. But now all of a sudden they got all these people that are saying, I need pain management for my chronic back pain or whatever. So the result of that is that all of those patients that can't get the pain management somehow get referred to palliative care. And so we find ourselves on this slippery slope where we're doing a lot of pain management on people that aren't even in a trajectory where they have a life-limiting illness. They are fairly healthy people with chronic pain, and it's really causing a problem, actually.
Very interesting, new problem with our new way of thinking about all of that. That's very interesting. I wanted to question about sort of the distinction. I think some of the confusion about palliative care and what it is might be linked to the fact that with the palliative care units in the hospitals are usually places where people actually are put when they're sort of actively dying. So I wonder how much of the confusion in the medical field as well is because of that.
It is. But my experience has been, for instance, I'll mention Summa because I used to work there, and they've got they've had this wonderful palliative care unit. Cleveland Clinic was the first place in the country to have a palliative care unit. And so the experience usually is that when there's a palliative care unit in a hospital, most of the folks there understand the difference. And the problem lies in the hospitals and healthcare systems so that really don't have that unit. And so patients can get admitted there under hospice in a hospital bed, but get hospice care. And then that becomes very confusing and all that kind of stuff. So there are, like at Summa, folks that are getting hospice end up on the APCU. And so from the outside, it might look a little confusing, but I think most people, because there's so much attention given to that, start to figure it out. At least I hope so.
Can I ask you, like I have a 97 years old mother. She's not like terminally ill right now. She has many issues, health problems. Should I like now, without like I talked to her about problem, what she wants if it's something happened like CPR or whatever. But you think I need to start looking for some hospice in advance, so when it's happened, I will be prepared?
Yeah, so that's a really good question. I would start by asking her, and if I could just ask one question, is she somebody that's going in and out of the hospital a lot?
No, she's not right now. Not. It was in the past when she went through the breast cancer, different kind. It was chemo and radiation. Right now, no, it's not like hospital always.
Okay. And so I think for now, I would just ask her, Mom, somewhere down the road here, you're going to get sicker. And how would you like us to approach that? Would you want to keep going back into the hospital to get treated? Or would you rather just have folks come in and help you stay at home and stay comfortable?
She wants home. I talked
Yeah,
to.
good. So yeah,
If it's something happened, she don't want somebody trying to return her to life.
okay. And so I think she's answered your question. That's great to know that ahead of time, because the problem is that when folks wait till there's a crisis, then, mom's having chest pain or can't breathe, and Mom, what do you want us to do? And it's hard to make a decision, but it's pretty clear that she would like to stay at home. I would just, take your time, do some homework, look at the different hospice programs around you, talk to people, get some recommendations, and just have it in your mind what you're going to do. And I'd probably if she has a primary care physician, I would let her physician know this is what Mom wants when the time comes. That becomes part of the medical record so that people know that when Mom gets there, that's what she's wished.
Okay, thank you.
Yeah.
Go ahead, Karen.
So when my uncle was getting towards the end, he had COPD and things were not good. And my family thought they could just call hospice right then and they would swoop in and take care of him. And they found out that no, you have to open an account or whatever beforehand. And fortunately he got better and they did that. And then when he got worse, they came in. But to kind of go off the last question a little bit, can you say a little bit more about that timing?
Yeah, so the timing can be tricky. And it really, it's kind of like I refer to, if there's a crisis, that's not the time not only to determine, but some hospice programs can show up like that, but many can't. And so it's better to try to, if you're starting to think that it might be an issue, to start making a plan for it. Because the second part of it is, let's say there's a crisis and you pick up the phone and you call hospice and say, we need you. They still need to get some documentation from the docs about, does your dad or a family member really qualify? So it's just a matter of doing some homework ahead of time. And then once that's done, and many hospice programs now, once they get the appropriate information they need, they can come in pretty quick and try to answer the problems that are right there.
I'm going to end it with, what's the average length of stay in hospice right now? Oh,
it changes, and it depends upon who you're talking to. I mean, it's been as low as 5 to 7 days, and I think now the latest is on average 2 to 3 weeks. But again, there's a lot of folks that last years as long as they continue to qualify.
No, that's a good number, because before it was like the point was people wait until really, you don't get the full benefit that hospice has to offer because you wait and wait and wait until really the end. So hopefully people are encouraged to think about those things earlier.
Yeah, and if as a closing remark, and that makes me think of this, is that when people enter hospice appropriately, not at the brink of death, so what happens? Well, they're just not sitting around waiting to die. They're living. Hospice programs will help them with legacy work, with going to do things that they always wanted to do, to help them wrap things up. I mean, the quality of life that having hospice involved can bring it can be remarkable. Not always, obviously, but it can be really helpful. So, and then once the hospice team gets to know the patient and family, when it comes time for the dying, it's like you've got this big family taking care of you. It's not a bunch of strangers.
All right, well, we've run out of time. I'm sure we could have gone all afternoon. Thank you so much for being with us and sharing your experiences. I hope everybody enjoyed it as much as I did and got as much out of it. So thank you.